welcome back, everyone. This is our most anticipated session of the conference, our Ask the Experts session. We have ALS clinical experts and research experts from across the state joining us in one place at one time to answer all the questions. So I'm going to start with introductions. We'll go geographically, so we'll start with northern Florida and work our way down south, and then we'll start with the questions. So, Dr. Oscarson, can I ask you to start? Just say who you are, what clinic you're with, and a little bit about your clinic.
I'm Bjorn Oscarson. I'm a neurologist and the director of the ALS clinic at Mayo Clinic in Jacksonville. I think we're the oldest clinic in the state, but I think maybe Dr. Pulley actually slightly north of me, so maybe should have started with him. My interests are in ALS negative care and clinic plasma ALS, but I also have the opportunity to work very closely with our basic science groups here at Mayo. Thank you.
Dr. Pulley?
Hi, I'm Dr. Michael Pulley. I'm at the University of Florida, Jacksonville ALS Center. I'm the director of the center. We have had an ALS clinic for about 12 years or so. And we are involved in clinical trial research and have a lot of interest in telemedicine.
Dr. Weimer, are you on? Okay, we'll come back. Dr. Gutierrez.
Yes, hi. My name is Amy Gutierrez. I'm in Orlando. I've been in Orlando for 2 years, and I'm taking over as ALS director for Dr. Laham, who moved to Pittsburgh. Prior to Orlando, I'm a professor of neurology at LSU Medical School in New Orleans, Louisiana, and founded the first ALS clinic in that state and ran it for a number of years until moving here. And now I'm back working with ALS patients.
Thank you. Dr. Gooch.
Yes, I'm professor and chair of neurology at the University of South Florida Morsani College of Medicine here in Tampa. I have a 30-year history of work in ALS care and research as a major part of my academic career. I was the founder of our ALS clinic here at the University of South Florida. We subsequently recruited Dr. Twan Vu to run it since my chair's job keeps me pretty busy these days. But I've stayed actively engaged in the ALS world, and certainly it's one of the things that I continue to focus on with my time and energies. So thank you for having me today.
Okay, Dr. Locatelli.
Good afternoon. Dr. Locatelli. I direct the Neuroscience Institute, the Phil Smith Neuroscience Institute in Holy Cross Health in Fort Lauderdale. I'm also the director or co-director of the ALS Center of Excellence, new Center of Excellence for ALS care. I'm very happy to join this excellent coverage through Florida, very good coverage Center of Excellence and clinics through Florida. So I'm very happy to join. I don't know the last one, but almost to the last one. So the new kid on the block.
Glad you're here. Dr. Granite.
Hi, I'm Volkan Granite. I am at the University of Miami. I'm the medical director of the ALS clinic at the University of Miami, and also actively participate in our clinical research program in ALS.
And last but not least, Dr. Vaughn.
Good afternoon. I'm Brian Vaughn, based out of Fort Myers at Lee Health. So our clinic goal is to provide comprehensive multidisciplinary team care to our patients and families with hopes of improving quality of life, reducing burden of care. As a recent update from with our clinic is that we transitioned from a Saturday clinic to Tuesdays. And so we're seeing patients every Tuesday, whether it's personal or telemedicine, depending on patient choice. Patty's there joining us on every Tuesday as well. So I'd like to thank ALSA for holding this vital event and appreciate our academic partners who are working tirelessly for us here and all of our vendors.
All right, well, thank you. This concludes our introductions. Now, we are getting some comments that there's some feedback noisy feedback coming through. So I think the best thing is going to be for everyone to mute themselves and then unmute when you're ready to speak. Let's see if that helps to eliminate some of the background noise. So we have some questions that have been submitted in advance. We have questions about clinical trials, clinical care, genetics, and environmental factors. So I'm going to start by reading some of the questions that were submitted in advance, and then we'll also take questions live from the audience. So if anybody is joining us who has questions, please feel free to put them in the chat feature, and we'll be monitoring those as the session goes on. So the first question is about the liquid version of Riliatech. The question is, why does it have a different name for a different formulation, and who should consider taking it? So who would like to answer that one?
I'll go ahead and answer.
I'm happy to do that. I'm Dr. Pullen.
Obviously, anybody that has swallowing issues should take it. It has a different name because it's manufactured by a different company, but I think it's a welcome benefit to a lot of our patients as they have trouble swallowing or with their PEG tubes. This way they could stay on the medicine if they want.
Anybody else have anything they'd like to add?
I actually had a conversation with the company earlier in terms of cost, if it comes up. So the cost is maintained apparently at the same price at the brand name Rilutech. So not the generic Riluzole, but the brand name Rilutech. That's where their cost is if insurance or approval is a question.
And again, the older pill forms of Riluzole can be crushed and given also. Again, the cost to the patient is generally not necessarily higher with the new liquid preparations, but they certainly have a higher sticker price in the end for the insurance company or Medicare or whomever is paying at the other end.
Okay. This question says, my husband wants to try metformin off-label, but can't find a physician who's willing to write the script, and he doesn't qualify for the trial. What should we do?
That's for Dr. Weimer.
And I think are we still connected?
Are you able to answer that, James? Or
I guess he's not on the line, but this is Dr. Pulley. I think for patients who do not qualify to go into any clinical trial, I have a lot more sympathy about trying drugs that are FDA approved for other reasons. The only drawback is we don't really know about safety of these things, and there have been drugs, for instance, lithium, that looks promising in preliminary studies, but then turned out to actually be harmful in larger studies. And so, I understand people want to try things, but with the idea that they have nothing to lose, but sometimes they actually might have something to lose.
Okay. This question is about secretions. It says, my secretions are excessive to the point that suctioning is required all day, and I can't tolerate non-invasive ventilation because of it. It has significantly negatively impacted my quality of life. Aside from medications that have all had unwanted side effects or don't work for me, is there anything else to address this symptom?
Well, I've tried a couple of things with patients that have worked well. Botox does work well, and I've even tried radiation with neurorad people, and patients have gotten good response from both of those methods.
I can echo some of that. We haven't had experience on radiation, but the Botox injections, we had excellent results. it's somebody that may be a little dependent on the person injecting it. We have somebody very good in our clinic, and we had excellent results, and we haven't had complications. So we're very, very happy in using it frequently. After trying, 2 or 3 medications, we are beginning to use it sooner rather than later. As we did at the beginning, we try more medication. Now we tend to go a little faster into offering Botox if that has a significant impact on the quality of life, like it sounds this case. So Botox is our next choice.
Yeah, I would just echo or mention that MyoBlock actually has a little bit of evidence that may work better than Botox. And that was written up by Dr. Carolyn Jackson.
And for patients to be aware, MyoBlock versus Botox are different types of botulinum toxin, type A versus type B.
All right, thank you.
Just to raise with colleagues, I'm curious for Botox, do you all wait, do you all would like to have a peg tube before doing Botox? Some are worried that, if swallowing complications happen because of Botox infections pre-peg, and some others are not.
In our clinic, we don't have worries about it. We inject without pegs.
Likewise, we also don't worry. We haven't had any bad outcomes in a very long time. We likewise have not had to go to radiation for a long time. Botox has become so easy to do that, there are some patients, because if you really have a long-term situation and plan on not needing to come back, where radiation could offer something that, because Botox does require people to return to the site. But again, it's a very long time since we actually felt that was the best option.
Okay. We have a question about medical marijuana. Now that it has been legal in Florida for a while, what do you see as the major benefits or problems with using it for symptom management?
Well, I'll address that first. I think some of the other panel will have some opinions on it as well. So medical marijuana is available. We do have some evidence that it may be helpful for epilepsy. In other areas of neurology, it's a little bit tricky. I think marijuana has certain properties that could be beneficial for ALS patients. Obviously, it has some anxiolytic properties. It also has appetite-enhancing properties, which can be useful sometimes for patients struggling with cachexia. And I think those are the two, anti-nausea as well, for those who might have nausea for various reasons. So I think in those spheres, it has some potential benefits. Who can prescribe it is a little tricky. I will tell you, here at USF, we're a state institution, and our dean of the medical school made a determination that because it still is a federal crime to dispense marijuana, that we as state employees would not be allowed to do it, even though the state of Florida has authorized it. So we're hopeful that sometime in the future, there will be some concordance at the federal level about medical marijuana, which will make it easier. We were prescribing it actually for a couple of years before the dean made this ruling, after the state of Florida approved it. So those would be my comments. Does it have any efficacy in terms of slowing the disease? I don't think we have any evidence for that. And furthermore, medical marijuana is a broad term that refers to all kinds of marijuana, but actually different varieties of marijuana have different levels of different kinds of cannabinoids and different quantities of THC. So they're really quite different. It's like different kinds of wines, if you will. And medically and scientifically speaking, we're just beginning to really understand and study the cannabinoid, endocannabinoid system in the brain where these drugs act. And we'll have probably better therapies and understandings of how they might work in the future for different things. I will say there was a big study done many years ago now, 20 years ago, I think, or so, on a drug called Marinol, which was essentially a prescription pill that was a distillation of some of the elements in the marijuana plant. And it was in ALS. And unfortunately, that study did not show any significant benefits on progression of the disease. Or survival, but again, it might have had some of these other effects. So those are my thoughts.
I can echo the same policy applies to our prescription patterns. We belong to a national chain of hospitals, so also the federal rule that not allow us to prescribe it. I am allowed to prescribe though Epidiolex, which is the approved indication by the FDA for epilepsy. But like Dr. mentioned, it's just a specific component of marijuana, which is the CBD oil, and I'm not so sure there's the same data for that, and I don't think that there's studies showing any of that. And I have no prescribed off-label the Epidiolex, which is the indication for epilepsy, the drug indicated for epilepsy in ALS patients. We do have quite a few patients that go to local doctors and obtain the compounds, the marijuana, and they use it. We don't know how much exactly they're using, what is the dosing, what is the frequency. There's a mixed report. Many of them report that they do well for a while. It sounds to me that towards more complications towards the end, they prefer not to use it. It sounds that there's a window in which they feel is beneficial, and then they decide not to use it on their own. I think it's a good choice for anxiety because it's not going to affect the respiratory drive. I think that's known, but again, there is use out there, and there's somewhat good reports that it works. But again, the dose, the prescriptions, we have no much of a control over what is prescribed because of these regulations.
Yeah, I think it's also useful for symptom management, anxiety, appetite, and even spasticity. I think there is some data in patients for spasticity. So I think it could have some value for that.
Some of my other patients also received medical marijuana through a dispensary, and the more frequent uses for pain or pain management because of their body and body positioning or muscle aches. So then again, is it preferential over opiates versus some of the side effects of opiates with constipation, lethargy, or even the respiratory depression? I haven't seen any major negative side effects from medical marijuana. If I do prescribe benzos or opiates, it's usually fairly low dose.
I forgot dry mouth is a side effect of marijuana, so that can help with the excessive saliva.
Okay, great discussion. So we also have a question about stem cells. Question is, what role do you think stem cell therapy will ultimately play in treating ALS? And what is the difference between the kind that's injected into muscles versus the spinal cord?
I can go first. I mean, again, stem cells are sort of like medications. Where will we cure ALS? I personally would guess it's going to be on the medication end before, again, a cell replacement therapy comes along. But from a regenerative standpoint, their stem cells, I think, would probably at least at some point be part of an ideal package. Stem cells are, again, like medications. There's no end to the different permutations or different variants you can make. And it's not one thing. Again, I mentioned during my talk the products we have with a mesenchymal stem cell that we use for injections in the spinal fluid. It's very similar to the Brainstorm product. Again, it is far from attempting a cure with this kind of approaches. So again, stem cells are very interesting. We're definitely looking at them. We'll continue to be looking at them in different forms. I mean, the first stem cell work was done maybe in the 1980s with bone marrow transplants. Again, it's something that's been worked on now for many years in ALS, and we'll continue working on it.
It's a very good question. It's a complicated question. We could probably spend an entire hour session on that topic alone. But to try to sum it up in a few words, in addition to what Bjorn's already said, stem cells were lauded. There's a lot of excitement in the beginning of our ability to culture and use stem cells, but they are a very complicated set of therapies. So stem cells can be programmed in different ways. So when you talk about stem cells, it's not one cell. You're really talking about thousands of potential cells that you could create. And that's what's happening now, of course, is the stem cells are being coaxed in certain ways. And the stem cells have two potential therapeutic benefits. One is they're little factories for growth factors of different kinds. So they support cells. They can help the health of cells. They may help with regeneration of cells by elaborating these chemicals and substances that support cell growth and survival. The second is the cell itself and its potential to morph into, say, a nerve cell and help to rewire the nervous system. The second one is the harder, higher bar. And because the nervous system is the world's universe's, as far as we know, most complex supercomputer, and billions of neurons, and each one having 100 to 1,000 connections. It's a very complicated thing to recreate. Having said that, the role of stem cells for elaborating these substances that may help with support cells is probably the first order of therapeutics. The neuron cells that they're creating have some of these properties of elaboration of these support substances. We don't know what the phase 3 neuron results will be yet, although they're coming out pretty shortly. So we should have results in that regard. There have been other stem cell studies done in the past, the recent past. The other challenge with stem cell therapy is getting them in the right place. Implantation, as opposed to just injecting them into the body or into the nervous system. There was a huge study that looked it included a number of patients, but it was a very intensive study where patients had surgery on their brains and their spinal cords to implant these cells directly through injection. That study was a safety study. It showed safety. There may have been some benefit for some patients. It was unclear. They needed a much bigger study, but it was going to cost a fortune, and the company could not find the money to get the big phase 3 study done. So that idea is sitting out there. In my own opinion, I think that they're very valuable in the lab for studying ALS. They may have a role in becoming little pharmaceutical factories inside the nervous system to help create a cocktail of growth factors, which may help. And if the neuron study works, I think it's going to spawn a whole industry of other studies that are going to be looking at ways to tweak these cells to help with survival and hopefully slowing of disease. But we will see. So I think that's where we are with stem cells. We're a long way from being able to regrow a brain or spinal cord, but they may help in these other ways.
Okay.
I would like to make a comment, which I think is quite important, which is the backside of the stem cell. Several patients that have come to our clinic, and I think most of us have seen examples of people receiving and paying high fees and high, and nationally or internationally, they will receive these treatments, which are not official, and they're likely to be not real. This is something that I would like to warn everybody.
Okay.
Please work with your doctors to see if what you're about to get is real. Do not pay excessive amount of money or go to trips to trying to get these stem cells. They're not real treatments. And I'd like to make sure you work with your doctor to see if that particular offering has, a validity that has any potential input. I'm most likely recommended to do it within a trial that you guys have.
Yes, please be careful. This field is rife with flam artists and scammers. You've got to be very careful. The best case scenario, you get something that is just water or it's normal saline. Worst case, and you get charged, tens of thousands of dollars. Worst case scenario, you get something that's harmful and can actually, kill you imminently. So please be careful out there. And absolutely, just want to second, if you're going to do that, try to get involved in a legitimate clinical trial at a major U.S. center or major European center.
Great comments. We have a couple of questions about roticaba and what you all think about it, if it's helpful. Someone is asking too that they heard that leg weakness progresses faster in those who've been on roticaba. What are your thoughts on roticaba?
I can make comments on a poster that we presented last year in Niels and in Australia. And we look at our site and we look at our patients. We have a method of tracking biomarkers and biometrics in our clinic. We have some data prior to infusions, and we compare those to themselves and the groups. And the overall all-comers, we didn't show a significant benefit on roticaba. However, I have to state that the study was really pointing to a fast progression subset. So there's probably a role in a subset of patients that's still useful, but the overall trying to use it in everybody in our clinic is we are very cautious about recommending it. Also, that the fact that there is infections on the ports, they do get infected, and there's a problem. And there's also a burden to receive these infusions, 10 days a month. And so there's some negatives to all of this and burden to the patient as well. So that's our experience in the center.
I would speak maybe with sort of slightly more enthusiasm for the drug. Again, the best data we have is limited, but does suggest that the drug works. The benefit on slowing disease progression is small, not again in the form that you would expect to be able to see it in a small single site series over a short period of time. Again, it's certainly not a miraculous drug. The study does have that potential with more falls in the treatment group, which again has led people to speculate if there is something that would sort of more save parts of the nervous system and more affect others. We don't have enough data to really say anything meaningful about that. And again, it's not a drug where we can really tell a difference. It's not that powerful. So again, it's not one where we, even if we see hundreds of patients, really are going to be able to sort that out. ALS, as you all know, is very variable. And we have some people who do very well on drug, and we have some people who do very well off drug, and sort of likewise on and off.
And I think I want to answer part of the question is that I am not sure that we have any data that people do worse if they receive roticaba and their disease started on a given part of the body. So I do not think that is an accurate worry. That's not a necessary worry. And on our end, I think we're also cautious, but we offer it on most of our new patients, telling them about the data that clinical benefit was really evident in people who were mostly doing well early in the disease, independent. And there were some strict criteria in the clinical trial. Unfortunately, insurance companies take those criteria verbatim rather than taking a patient as early disease, independent. But often we experience insurance problems if in ALS functional rating scale you may be hearing in your clinics from your doctors. If one of those points do not meet, sometimes insurance companies will deny the medication. So just another note I wanted to make.
Anyone else? Okay. We have a question about exercise. Even though I have ALS, I'm a very active person. I go to the gym or exercise at home since COVID. How do I know when to cut back? How do I arrange my exercise program to meet my diagnosis? And are there better forms of exercise for someone with ALS?
Sure, I'll field this question, given that my specialty is rehab. Anyway, so with looking at neuromuscular disorders, the goal and the aim of neuromuscular rehab is to improve cardiac and lung function, as well as perfusion to your other vital organs, decreasing hospitalizations, improving quality of life, prevention of any sequelae such as skin breakdown, contractures, pain, and whatnot. But at the same time, so exercise is important. We look at different sections of it. If you're talking about intensity, duration, and frequency, there are some standard calculators that we look at. For instance, let's say intensity. How long should we be doing it? 5 minutes, 10 minutes. It really depends on the person, what their fitness level is beforehand, and what they're functionally capable of doing. Let's say if you are a person who's still able to walk 2-3 miles a day, that function is still relatively safe if you aren't very fatigued the day following or having increase in shortness of breath. We like to look at vital signs, blood pressure, oxygen, heart rate, any type of arrhythmias that you may have. So ALS doesn't preclude you from other types of comorbidities, heart disease or lung disease or any other disease. So we look at it as a whole. So what type, to try to answer that, what type of exercises, rhythmic exercise, aerobic, you can participate in isotonic exercises, such as ones where you're lifting weights or resistance, but there's also caution advised with that, because how heavy are these weights? Are we talking about TheraBands, several pounds? I would generally not recommend heavy resistance training. And if you do participate in that, then it would be more of a mechanical or machine where the motion is in one certain direction, where you don't cause pain or drop weights or fall or have any further injuries. But yeah, so that resistance training, active range of motion, joints, body positioning, frequency of turns. So if you're wheelchair bound, how frequently can you turn? Are you able to activate your core muscles? So just by turning, you're activating your core muscles, your muscles and intercostals, your arms, your back. Trying to have a erect posture, shoulders up a little bit. A lot of folks tend to lean forward, but at the same time, it's not that they want to. It's just the dysfunction of the disease itself. But yeah, there are targeted heart rates. Looking at your there's a scale called a Borg scale, Borg rating. How active is that activity? How much consumption of oxygen is it requiring? Is there a warm up phase, warm down phase? But in general, it's activities of daily living, things that you do, such as getting dressed, transferring, showering. Those are all activities. Those are all exercises. But for those who are more capable, they can continue resuming doing what they're functionally capable of doing. But I would definitely look at your oxygen level and your heart rate as vital signs.
Thank you, Dr. Baum.
I would just like to add to that. That was great summary. I think it's important for ALS patients to probably get a physical therapy consultation to really tailor their regimen to their particular situation. That's very helpful. And then as a general rule, the patients worry about this age-old question: does exercise make me progress faster? Am I going to damage my muscles? And I think the answer to that question is that mild to moderate exercise is actually beneficial in ALS. It's been shown in a number of studies. But you need some guidance depending upon where you are in your disease course as to what to do. Generally, I tell my patients, if you exercise to the point of muscular soreness or to the point of undue fatigue, such that your muscle feels weak after the exercise that you've done, that's probably too far, and you scale it back. But it's very, very important to do, as just was outlined, to do the exercise that you can do. Get with your physician, get with your physical therapist, and make a plan and try to stick with it. It will help you.
I would like to add something that Dr. Lauren Taylor brought to our center is the exercise of breathing exercising. There's different techniques, so not to forget all the details in this, but breathing exercising with breath stacking or repetition, there's protocols that have shown that you can improve your breathing and increase your vital capacity for a while if you do also breathing exercises in addition to the eloquent presentation to the rest of the exercise.
So, question about who gets ALS. Military vets are twice as likely to get ALS, but no one understands why. What's your theory on the answer? And besides athletes, are there other groups of people that seem to be more at risk?
Yeah, I'd like to jump in about the veteran question, which I was involved in the Institute of Medicine study 20 years ago that looked at this question and brought it to light. It's true. There is a higher incidence of ALS among veterans, and the VA has made it a service-connected condition because of that, primarily as a result of the Institute of Medicine report. Interestingly enough, among the service branches, the Air Force actually seems to have the higher incidence, but that's unclear why. And this all came about as part of the studies that were being done around the time of the Gulf War in the 90s. The Gulf War syndrome was something that was being looked into at that time. And there were a lot of spin-offs to that. And one of the questions that came up was ALS. Well, my personal feeling on this is that it's most likely the same mechanism that causes ALS to be more prevalent in athletes. So, for example, another group that's affected is varsity athletes in college. So if people were varsity athletes in college, they're more likely to get ALS. by a statistically significant margin. And of course, Lou Gehrig, many other famous professional athletes have gotten ALS. People who go into the military in general tend to be physically fitter than the general population. They're selected for that purpose. They're screened for that because they need that to carry out the duties that they need to carry out as a military person. So why it is that people who have athleticism, if you will, may be more prone to ALS is a bit of an open question, but there are some interesting theories. So one of them, which came from Bud Roland, who was a famous ALS expert in the 20th century, is an interesting one to me. And he believed that that people who have exceptional athletic ability are, if you will, not normal, that they have a genetic template that gives them superior performance in terms of muscle and nerve function. And that there probably is something about that particular mutation, if you will, or set of mutations that gives them this athletic advantage that also makes them more vulnerable to the mechanisms that kick off ALS. It's a theory. We really don't have a lot of evidence one way or the other as to why. So there's a lot more that could be said about athletes and ALS, and then there's the whole concussion question and all those things, which seems maybe not to be as connected as we thought, but that's a whole nother discussion. But I think that's my take on the issue. I'm very glad the VA long ago recognized this as a service-connected condition. It really helps our veterans with ALS to access a variety of very important services, and they are definitely at greater risk. And I'm sure some other panel members have comments.
Yeah, I mean, we view genes and the environment as sort of building together towards disease in most states. And where we're standing in ALS today, we largely only recognize monogenetic diseases, where a single gene almost guarantees you're going to get disease. It's a little more nuanced than that now, but that's kind of basically where we stand. As we come to understand genes and environmental interactions, we're probably going to have a much more complex picture of this in the future. But today, I mean, what we really recognize and understand are these kind of single gene processes. On the environmental side, it's very little understanding there. Again, there seems to be something with the US military and athleticism, maybe some things with some other types of environmental exposures. Smoking does come out fairly consistently, and I would say that we would consider smoking as an established risk factor, though it only marginally moves the risk up. So it's, again, there's so many other things that are happen more frequently to smokers, but ALS is probably one of them.
I think overall we don't know exactly so we don't have a way of preventing this. I mean, it would be nice to smoke, but unfortunately, I mean, we exactly don't know why we get it unless it's a gene related. I would advise the non-patients we should not stop exercising because of the minor risks. So we should make sure. Hopefully, we'll know exactly modifiable risk factors one day. But these are minor increases. Each one of these little risks, and then a perfect storm sometimes causes the disease. That's what I try to. Well, that's how I explain to my patients: genes and environments, and a perfect storm. We don't know exactly why.
Yeah, a very important point. There's no evidence that exercising causes ALS. So just to hammer that point home. So the benefits of exercise are humongous. I mean, for everybody. So everybody should exercise. So just be clear about that.
Okay, next question. I am experiencing fasciculations in my tongue. Does that mean my speech will start to be affected? Why do fasciculations happen?
All right, so fasciculations are a feature of the lower motor neuron dysfunction. That's almost completely true. So again, that is the nerves are going out to your muscle, and it has a tendency to fire too much. That's what we're seeing as these twitching. If so it is a feature of your lower motor being sick. It doesn't mean that that's where the disease is going to go next, but certainly could suggest that. It's not a guarantee that that's where your next problems are going to be, but it is. I don't even know if we really truly have sort of statistical measures of that. Again, everybody fasciculates. We can now make more careful measures of fasciculations using ultrasound and so on. But again, sort of when do fasciculations really become abnormal? Because they certainly are abnormally frequent for many people with ALS. And again, just kind of, I guess the disease will do what it will do. And this doesn't necessarily mean that that's where your disease is going to be noticeable next.
This is a question about the different forms of ALS. Oh, somebody else going to add something? Okay. I heard there are genetic forms of ALS that do not run in families, or genes that are associated with ALS in sporadic forms of the disease. Is this type of ALS different from the familial form, and if so, how?
I can start answering this. So I think first, we may not know exactly. Sometimes in at least certain genes, not all the genes, the gene may be in the family, but not every person carrying the gene may get the disease. This may be because the disease was going to become apparent at the age of 70 and the person died at age 65. Or the gene is not penetrant. Penetrance means the risk of getting the disease if one carries the mutation. So all in all, I think while the numbers are not exact, out of 100 ALS patients without a known family history, still 5 to 6% of the time, we tend to discover, if we test a broad number of people, a gene that may be causing ALS, and the C9orf being the most common among these genes.
Well, I think it's important to point out to our viewers the difference between strictly hereditary, traditionally hereditary disorders, where if you have the gene, you have a 25, 50, or 100% chance of having the disease, and then risk genes, very different. So there are diseases, and there are some forms of ALS that, if you have that gene, we know you have X risk for sure of getting the disease. Very little variable depending upon the specific gene. However, we're discovering more and more, like every few months, of what we might call risk genes that are overrepresented in ALS patients. In other words, ALS patients are more likely to have them than people in the general population. But plenty of people, millions of people in the general population have them and never have any problems. So it's complicated, and we're trying to figure that out. As is it like a combination lock? If you have 3 or 4 or 6 different genes together, is that going to get you in trouble, or is it these 3 genes plus an environmental exposure? These are things we have to figure out yet, and we don't know. So if you have one of these risk genes for ALS that's not truly hereditary ALS, then it's likely that your risk of ALS is very low still. But you need to talk to your doctor about that. And then, of course, if you have a known hereditary form like SOD ALS in your family or something like that, that's different. And that has a fixed risk that we know about. So please don't be frightened if you send off or have a genetic panel done on your own and you see that you have, specific kinds of genes that may have been associated with ALS. It doesn't mean necessarily that your family has hereditary ALS. You should seek genetic counseling or talk to your doctor.
As far as the clinical manifestation of ALS, most of them are all pretty similar. So you can't say because my ALS started bulbar that therefore I have this cohort of genes. So the genes are a very interesting component that we've now learned, especially in the sporadic cases, but it doesn't, clinically, we can't say, oh, this person is more likely to have this gene than not.
We have a question about the decision to get a trach and what you advise are the most important factors to consider.
So that's a very personal question, and I would say majority of patients do not elect for a tracheostomy tube. Some patients even have concerns about a percutaneous a feeding tube extending the life expectancy. So the goals of life and quality of life is a very personal question, and that option is available to all patients if they so choose. And in each clinic here, we probably each have a subset of folks who are um, ventilated through mechanical ventilator 24/7. Also have percutaneous tube for feeding, power wheelchair. There's communication or communication devices with eye gaze or some other method that the family develops with one another. But it's a personal question about quality of life and how long do you want to be sustained by mechanical means. And so it's not a so the question was, when should they get one, or if they should receive a tracheostomy tube? It's symptomatic weight loss, feeding. It comes all together about the care of the patient, and if they're at high risk for other complications, pneumonia and whatnot. But they're all foreign bodies. They're going to put you at risk for other forms of complications besides ALS.
Yeah, I would echo the same thoughts. I think it is a very personal decision, but it's a decision that should be thought about and consulted with the family, because the family does have a big part in that decision making as well, especially if a patient does plan on going on a vent. There's a lot of care that's needed. And it's a decision that's best made proactively than reactively, and not wait until things are really dire and then you make a reactive decision to go on the trach, which may not be the best for all involved.
I think it's important for patients to understand that it's a decision that can be changed. That some people, I've had patients who initially said they would never consider it, and then when push came to shove, they decided that they wanted to have a trach. I've had other patients who had a trach and then did not like their quality of life and decided to go on set attempts and have the tracheostomy withdrawn. So it's not a set in stone decision in either direction, and it is totally the patient's decision. But again, I think, as was pointed out, family members have to be involved because they're the ones who have to care. The patient can't take care of themselves on a ventilator, unfortunately.
Yeah, I want to build a little bit on the moment of the recommendations and the changes on your thinking about it. We have to change a little bit the local culture of Holy Cross, because you end up in the hospital, the pulmonologists or the intensivists are quick to react to recommend the trach because they have a very short, goal. Okay, you need it now for the next few days. They're not thinking in the long term. So the advice from other doctors with other specialties sometimes is difficult because they don't have the same goals as we, the ALS care, doctors have. So things that I mentioned, just to repeat, think about it early on, allow yourself to change, but make sure you have good advice that is not changed on the rush of the moment when you end up with an urgency in the hospital, because pulmonologists in general terms will advise you that that's what you need, that's what you must have, which is not real, because it's a little bit bigger question what you want to do long term. And again, I'm going to echo what you just well explained. It depends on you and your family and your caregivers. Do not let the pulmonologist of the heat of the moment to change your thought because you're rushed to do it.
And I would, again, with that long-term thinking in mind, where will you be getting your care? Is it a possibility that you can go home with your family and get the care you need in your home? Or will you need to go to a facility for the continued care? That is a factor that I know matters to a lot of people in making this decision. And again, if you are going to try to set up a situation at home, that needs to be a discussion with the caregivers that's going to be supporting that care, and that we kind of make sure we can bring the additional resources that are required to care for somebody in the home on a ventilator. It can be done. You definitely have people and families who do this successfully, but it requires a team. It's not something a single person can do ever.
To add to what Dr. Pooley mentioned earlier about reversal or obtaining and reversing it, so it is reversible. Anecdotally, I had patients who were treated in a long-term care facility with minimal ability to communicate. I've also had other patients who have locked-in syndrome where they can't move or can't communicate, or even dementia where they're not able to say what they want. So it has to be very clear at what point in time is there a period where you stop the ventilation for if there's going to be if the patient's going to expire or not. But it has to be very clear cut in the beginning, so the family is all well aware.
Thank you. We have a question about ALS hotspots. So this question says, I live in Central Florida in a rural agricultural area, and there seems to be a high number of cases of ALS. Are there hotspots of ALS, and are they being studied?
So I'll start with this one, and I want to tie this to a question I think I saw coming up about the cyanobacteria question, blue-green algae. So there have always been clusters of ALS from the time ALS started being studied, and we began to really take account of the spread of ALS. There have been famous clusters. In the 1980s, there was a cluster of 2 or 3 Miami Dolphins football team players who contracted ALS within 10 years of each other. There are cases of conjugal ALS where husband and wife both come down with ALS. There are other clusters that have popped up over the years in many different settings. Every time that cluster pops up, researchers tend to descend, and epidemiologists, and start looking to see if they can find a common thread. So far, we've not been able to identify clear common threads. It's happened at different places throughout the country. There's always a question of, could an infection be responsible? And that's another whole area of ALS research that's been looked at. Or do certain kinds of infections predispose people to ALS? And the answer is unclear. We certainly don't have any evidence that a specific infection unequivocally increases your risk of ALS, but there have been population-based studies that suggest maybe this or that infection might move the needle a little bit. Here in Florida, we do have this question of cyanobacteria, and cyanobacteria are the bacteria that live in the water that make ponds and things so beautiful blue-green colored. When you're in the airplane, you see these beautiful blue-green ponds. Those are cyanobacteria. The cyanobacteria, unfortunately, also elaborate something called cyanotoxins. And cyanotoxins can be carried in water vapor in the atmosphere. There was a cluster about 5 or 6 years ago, unfortunately, around Cape Canaveral, in 3 NASA employees that all lived within about a 5 or 10 mile radius, actually closer than that, of the same large lake that had extremely high concentrations of cyanobacteria. Because of that, we put together an entire NIH grant to study the impact of cyanobacteria with the University of Miami. Walter Bradley was behind that, who's the previous chair, Michael Benatar's predecessor for many years in the ALS clinic there. And we at USF were also involved, and we put it before the NIH. Unfortunately, they did not want to fund it, so we don't have the answer on cyanobacteria at this time. But we do know that cyanotoxins can be neurotoxic, and it remains an open question. But apart from that cyanobacteria issue and story, I don't think we have clear answers for any of the other clusters that have popped up over the years.
Question about managing COVID-19 risks. So how do I manage COVID-19 risk while I'm trying to manage ALS? I used to go to outpatient PT, but I've stopped. Is it safe to have PT come into my home? What about other health aides? Trying to balance quality of life with managing the risk.
So I think it still comes down to hygiene and personal protective equipment. So if you're going to have people come into the home, is it a risk factor? It definitely is a risk factor, but how high is that risk factor? But the best what you can do is, as what Dr. Gu said, everybody should be exercising regardless. So masks, hand hygiene, gloves, alcohol. And if you are to that extreme, then the recommendation of, let's say, a gown of sorts or disposable gown is pretty hard to obtain at this time for in the community. But those are protective gears that you can ask the therapist or whoever is coming into the home, whether it's nursing staff, PT, OT, or speech, or a CNA, to create a barrier between the patient and the care provider.
I want to make a comment. At the beginning of the year, I was asked to help with the chief medical officer of the hospital, and that being the incident commander for the COVID response in Holy Cross Hospital. I've been doing that for the past 9 months. We've been looking very carefully at all the infections in the hospital and many of the infections that we detect on the patients. Interesting enough, most of the infections are not through the medical care. They're not on the risk of coming physical therapists. Including the associates, all the patients will tell you the story that the infection came through the back door. I call that when you're facing the patient, everybody use the protective equipment. That's when the infection does not occur. It does occur when they all relax. They go to a break room and they chat. They know the friends and it happens. And their homes usually tend to happen not through the interaction with patients, but when these nurses or other associates chat and they're relaxed with friends or family members. So that's where they get the infection. So I would say there's more risk of getting the infection from a family member or a friend that you trust, that you will let your guard down, as compared to a physical therapist that will go to your home, or when you go to a physical therapist and they will all be up and guarded with protective equipment. So be as careful as with a therapist, but more so with the people you know and friends. Then they might be bringing the COVID to your home and not through the medical community.
I just want to add on that this is more of an opinion than a medical fact. But so first, I think we should not let our patients, the quality of life should continue. And one of the things in, for instance, ALS quality of life is, not having shoulder pain because we haven't been doing physical therapy for, 3 months because of the worry that a physical therapist will come home. So yes, COVID, let's say in a patient with significant respiratory concerns, if that person gets COVID, you may worry that the risks could be higher, but overall, I feel, and my colleagues in my clinic feel, that life should continue with caution, not the cautions that we should be all taking in COVID, but therapy and treatment should not stop.
I want to make sure that we have time to get to some questions. Oh, go ahead, Dr. Gutierrez. Okay. There is a question from one of our board members that's the chair of our advocacy committee, and she says to the esteemed panel of experts, thank you for all the progress you make. What is your wish list for our Florida advocacy team to target that you need, federal and state?
I'll start on that one. So first of all, I would like to, extend my thanks and congratulations to Florida ALSA for their successful championing of the Bittner Plan Initiative through the legislature this year. This is a great initiative which does help to underwrite ALS care in the state of Florida. It was in my opinion, an extreme long shot in this challenging budget year, even before the COVID pandemic, but it did make it through. And so hats off to all those people who were involved in that. I know Ray and the whole team did a great job, really amazing that they pulled that off in this budget year in Florida. And the reason that's important is we all in our clinics know that when we provide multidisciplinary care, we often do so at cost. And it's very important to continue to be able to subsidize that care so we can continue to offer it. Here in the medical arena, we're having fiscal challenges just like everyone. We all of us, have slowed down our clinical activity for a month. Our institutions, closed down surgery for 1 or 2 months. So it's a very, and the state of Florida, by the way, just cut our budgets if you're a state institution by substantial portions. So because of their fiscal challenges. So we definitely need the extra support to be able to continue to provide high quality multidisciplinary care to our ALS patients, since unfortunately Medicare and other insurers do not pay for all the things that you all need. But we do provide it, we want to continue, and Bittner Plant will help with some of that. But that to me remains a very high priority. And we appreciate everyone that continues to support the association. The absence of the walks has been a huge blow financially to all of also chapters nationally and including Florida. But we do encourage everyone to continue your support of the association so we can continue to provide these services. So that would be my wish list, and it's already been partially granted, but we have we need to continue. Thanks.
I would just second that.
Okay, now we kind of have some big picture questions. So, what's the biggest or most significant scientific advancement in ALS over the last 5 years? And what is the greatest challenge researchers face over the next 5 years?
Well, there's two.
I think. Dr. Cooley, please.
One was the approval of roticaba. It's only the second drug that's been FDA approved for slowing progression of ALS. So that was very big. The second one that is in progress that looks very, very promising is genetic therapy for SOD1 ALS. And I think there'll be certainly other genetically based therapies that will be coming in the near future. I think those are probably holding the most promise for select patients, a small proportion, unfortunately probably not for the majority of patients, but for those who do have genetic forms of the disease in the next 5 years. I think genetic therapies will be a big breakthrough that's going to continue.
I'll echo what Dr. Pooley said. I think the genetics are very, will unlock a lot of the mystery down the road. So I'm really excited about that. I also feel that with the advocacy and from all the organizations and then from individual like Steve Gleason's organizations and such, Neil's, there's a lot of trials going on that are really very exciting, and to have so much energy being put into ALS and having so many compounds being looked at is really quite exciting, because for a number of years, really, there was a dearth of just research being done. So that's really exciting, and it's because of all the advocacy and funding that we've been able to do that.
And I would say an increasing focus on therapeutic development, which has always been a big point of ALSA and the community and those of us who are researchers, but developing really new paradigms that will expedite the testing of new treatments. You've already heard earlier today about the Healy platform concept, which was something adopted from oncology. And it's going to be great for ALS to speed along the trials, so we aren't stuck in this pattern of very slowly one after another. We can do parallel processing. And I think that's going to speed up therapeutic development, our ability to churn through different options and see what works and what doesn't work. So I think there's more and more momentum in that direction, and that's great.
I would kind of also say the idea about genetics and where we'll see most of the action. But if I was going to pick something else, maybe, I mean, again, so this is sort of speculative. if the discovery of the statin 2 that may kind of actually leverage the prior understanding of the TDP into something that actually will be actionable about this sort of what we perceive as a fundamental issue in ALS, into something that actually can help people maybe as early as 5 years from now, that would be something for everyone, not just the genetics. So that could, I mean, again, that's a wild, it's a hope. It's the, I think the lead candidate right now for something that's really going to be meaningful to everyone.
Yeah, and I just want to say, I know many of our patients and families listening may not have a genetic form of the disease. Most of you don't. Most of you have a sporadic form. And that doesn't, I want you to understand that although we're very excited about, being able to make progress in these genetic forms, for those of you who have them, it's great. And we're moving hard in that direction and going to have, I think, some significant developments pretty soon. But for those who don't have those hereditary forms, there's the bulk of our research is still focused on you. And when you hear this talk about genetics, I think what everyone is thinking is that, look, these genes give us clues as to what may be going on. And just as Bjorn said, we're all looking for a downstream something that we can tweak, interrupt, stop, that will actually create benefit for everyone who has the disease, sporadic or not. And maybe it comes down to being able to profile people's risk genes and put certain things in to stop the process from moving forward. Or maybe it's partially regeneration, or maybe it's a combination of all these things together. So there's a lot of activity going on really in sporadic ALS. The genetic developments, we all hope and have reason to believe that they will ultimately also help you with what we call now today sporadic ALS. So just be aware of that.
I want to make an addition. So most of my colleagues said, genetics made a huge difference. And the difficulty in ALS has been all the challenges. We don't understand what starts the disease overall. And I think making progress will really depend not only clinical trials, but also observational studies. So the more we understand the biology of this disease, the more success we will have in treating the disease. So participating, even of those people who do not participate in clinical trials, participating in observational studies that are geared to understanding biology are huge. So from here, for everybody, all of our patients, I highly encourage participation one way or the other in research, even family members as controls. It's huge in helping now and in the future.
Well, we're coming to the end of our session. I want to thank all of our experts. You did a phenomenal job in our new environment. We appreciate you giving our session here a new try and our new normal. And thank you all for answering questions on the chat feature as we were going. You're the consummate multitaskers, and it clearly shows your dedication to our ALS community. Is there anything else that you were hoping to cover? We covered a lot of really interesting topics, great discussion. Anything that you wanted to you were hoping somebody was going to ask about or wanted to add? Any final comments or final thoughts?
Yeah, I have something to address to the patients that's really not scientific. And I know that a lot of people are discouraged. And they're discouraged not only because they're fighting this tough fight against ALS, but they're discouraged because here comes the COVID pandemic. And so we've all lived through that the last few months. And I've heard from a lot of patients concerns, fears, anxiety. Is this, first of all, there are the challenges to care, which I think we've largely overcome, fortunately, over the last few months in our different centers and caring for ALS patients and providing ongoing support that way. But there's a broader concern among ALS patients. What about research? Is everything grinding to a halt? What about my hopes for therapeutic development? Is this all coming to an end? Is it going to be too late for me? Is COVID going to keep me from getting what I need? And what I want to tell you is that is not true. So we had a little pause for here at USF, and I know at other places. That pause lasted for not very long. It was only a few weeks. When we slowed down clinical activity, we learned ways around with telehealth and other things. Laboratories temporarily closed, and then they started back up pretty quickly within a space of really a month or so. So basic science research continues. Clinical research continues with modifications to accommodate COVID. We have results coming out. There's results. Amylex is now going before the FDA for potential approval. For example, Neurone is coming. The end of that trial. We'll see what that trial showed. We have other studies that are in progress. So research continues. I do not want you to be discouraged. We are not giving up the fight because of COVID. While we had to figure out how to retool and continue, and we have, and we are. And this is the story all around the world. So don't feel like that, oh, the show's over, everything's stopping, and then there won't be anything left for me in the time that I have. That is not true. We are working every day. And I just want to also reassure you about the tremendous dedication of the people of ALSA and the scientists and physicians who are studying ALS every single day in thousands of centers, thousands of laboratories all around the world today, working on your disease right now. It is our passion, it is our goal to cure this disease, to see ALS ended as soon as we possibly can. And our passion, our dedication to this has not diminished. ALSA's dedication has not diminished. We are with you. We are behind you. We will not give up until we end the disease. I promise. Everyone continues forward, and we're 100% behind you. Don't despair. We are fighting for you every day.
Certainly echo.
Well said, Dr. Gooch. Thank you so much. I'm now going to turn it over to Marixa for closing remarks.
Hello, everyone. So good afternoon. My name is Marixa Salgado. I'm the Regional Program Director for Central Florida East, the ALS Association Florida chapter. So you have seen me through the day. I thought I would introduce myself as I close this amazing 7th annual Hope and Health Symposium. We want to congratulate all our award winners today and thank them once again for all of the support they give us day after day and year after year. All sessions today were recorded. If you missed anything or feel like you want to look at a session again, please feel free to do so. On behalf of the ALS Association Florida chapter, I want to start by thanking all of our sponsors for standing with us and bringing you so much important and needed information and opportunity to speak with them. They will be at their virtual tables until 5:30. If you have not had a chance to visit them, please do so now. The gamification winner will be announced at 5:30. Our apologies to NSM, our lunch sponsor, for technical difficulties. I hope you had a chance to visit with them in their expo booth. We want to also apologize for the technical difficulties we've had throughout the day. We will post presentations that were missed on our website. We would also like to thank the teams in the Learning Lab that have been working all day to answer any questions you may have on how to, from durable medical equipment, transportation, respiratory needs, and communication, to dietary, physical therapy, and occupational therapy. They are all also available until 5:30, so please stop by if you haven't had a chance. I want to thank all of the persons living with ALS, caregivers and family members, as well as those that have a connection to ALS that attended today. We know it was a long day, but we hope that the information and speakers we brought you today answered some questions that shed light on ALS. Lastly, I want to thank the ALS Association Florida chapter staff for all the hard work that went into this event, as well as those from the ALS Association that attended from our national office and other chapters across the nation. The team at the ALS Association Florida chapter would not be able to do all that we do without the leadership of our president and CEO, Ray Carson. Thank you for your support every day. This pandemic may have changed our service delivery and our ability to bring you events like this one in person, but it could not change the passion and commitment that we have for the families we serve and the jobs we do. Remember, until there is a cure, there is care. Thank you.